Improvement Week that have been from 26th to 30th of this month. And we are really excited at the kind of conversations that have happened here and just the commitment that we all have towards improvement of the quality of care patients receive in our institution and as a country, the framework which supports quality improvement. Once again, let us just remind ourselves what we have sampled this week, and those who've been here through the week can attest that there have been very exciting discussions, very useful, pragmatic, that we can take and hit the road, at least from one way or another, as we provide care, as we lead the health sector, and even as we work among the communities. So on Monday, we had opportunities to look at the tools, approaches, and models for quality improvement, and even had some case studies from Kitui and KNH, and the main presenter was Peter Mutanda. Coming to Tuesday, we went to the national and were able to be taken through the certification and accreditation framework for quality healthcare in the country by MOH. Dr. Aisha did a great job, and we had various quality management systems or the various standards that people are using voluntarily. And she also brought to us that KQMH will be the mandatory standard for us to have to adhere to. And so we got safe care, experience, JCI, ISO, and also the KQMH pilot. It was a very accreditation framework. Then come Thursday, went to an enabler for quality improvement, which is leadership or QI. And we had case studies from where Dr. Kerry and Dr. Panga were able to take us through the various projects that have trained healthcare workers to identify areas that need improvement, have an enabling framework for that conversation and for simple interventions that make a difference at the bedside, at the survival of the babies and mothers was implemented through their project that emphasize on leadership capacity. We're also able to have experience from the counties, the submission hospitals, a very good presentation by Milan from Chogoria. We also went further to get a presentation from Kijabe, and we also had a presentation from the Health Managers Society Association. So it was a real rich day. And as an overflow of yesterday, we have today that will be handling matters resilience during COVID and also leadership. So Emily from Kikuyu will share with us experience, and we're excited that yesterday we were quite having some discussions about these matters. We were unable to finish, but today we have another opportunity to have a test of that case study from Kikuyu Mission Hospital. And today still we'll be having panelists. That is, we'll have Dr. Mary Adams, who works with maternal and neonatal childhood program for Kijabe. And we'll have Lynette from LVCT, who will talk about this perspective from the community and the interventions that have been done for quality improvement in healthcare. We'll also get an opportunity to talk to Frank Wafula, a representative for quality healthcare, and at the same time also a lecturer in health policy at Strathmore University. We'll also have opportunity to get some comments from Emmanuel Milimo, I think from Farm Access in Kisumu. So we have a rich program before us, and we are glad that we're able to have this as the climax and the end of our Quality Improvement Week. So Quality Healthcare Quality Division at Kenyatta National Hospital is housed at number 28, just above the National Bank. And we report to the Senior Director Clinical Services. And under Healthcare Quality, under Healthcare Quality Division, we have various units, and one of them is process standards and process improvement. So this is the department, or rather the unit that has hosted this event. It's led by Agneta Chelimo, and we have Carol Malingu also in that department. So kindly note the contacts for the speakers that we will give for these important units, standards and process improvement. There will be the link in case of any further follow-up to this conversation. Thank you very much. Without much further ado, allow us to dive into our main presentation for today. And we really appreciate Kikuyu for coming again and for giving us for not having their chance yesterday. But we know that God's timing is best. It happens to be today, and we are glad and ready to enjoy and learn from the presentation. So Emily Omari works for Kikuyu Mission Hospital. I will ask her to introduce herself in full, but I know Emily leads the quality assurance department in that institution, and she is enthusiastic about matters quality. Karibu sana, Emily. As Emily starts, allow me to ask members, you can type questions, comments on the chat box at the question and answer place, then we'll be able to respond to them as we learn together. Asante. Are we able to hear you, Emily?
I don't know. Can you hear me?
A bit faint. Let me see whether my colleagues can hear you. Emily, we're hearing you, but very faint with quite some echo. Is there anybody in the neighborhood who's also tuned in with the echo? If you are tuned in using two gadgets in the neighborhood.
Now?
Yes, now we can hear you. Yes.
All right. Thank you so very much, Lydia, for this chance. And I want to thank Kenyatta Hospital for what you're doing. This week has been quite impressive for somebody who is so passionate with matters quality. My name is Emily Omari. Is a qualified registered nurse. I trained in Kenyatta. So when Kenyatta is mentioned, my heart is always grateful. And I've done health systems management, and currently I head quality affairs in Kikuyu Hospital. Kikuyu Hospital is along almost near the bypass, the southern bypass, near Nairobi University, Kikuyu campus, and Alliance Boys and Alliance Girls. Those are our neighborhood, and the Thogoto Teachers Training College. When I logged in from Monday, the issues quality presentation were quite nice. Then by Tuesday, when the presentation was done by the Ministry of Health, Dr. Aisha, about accreditation, it was so passionately given out, plus Walter Kibet from AMREF. And also another presentation that was quite nice was from Aga Khan University Hospital. And then yesterday, again, all the presenters, Nanyuki, Chogoria, Kijabe, I want to really say the quality in healthcare is now coming up. And I won't forget my HESMA office secretariat, Dr. Kimemia, who really did something nice on quality. So today, as we talk about leadership in continuous quality improvement, and especially in these times of COVID, I want to do something about Kikuyu, what we've done so far, and our experiences with quality. I'm trying to share my screen. All right. So when we start, for example, talking about quality in healthcare, it's not an easy concept to people who really don't know much about it, but it's something that is now coming of age. And I want to narrow it to leadership in quality. And when we talk about leadership, I want every person who is in this webinar this afternoon to know, not to say the leader is the CEO up there, the hospital administrator, the ward in charge, the departmental head. Just in case you are a leader, even in charge of the emergency trolley, a leader in charge of cleaning a department, that is your position. You are a leader and this thing concerns you. It is not everybody's favorite subject, because whenever they hear quality, they hear audits, they hear somebody coming to harass them, they hear somebody coming to interrupt their working system. And other times somebody will say, let those people of quality come. When they finish, we go back to our own self. So we are in healthcare right now, we are trying to see the way we will bring all the healthcare workers into one agreement, which means that quality will not be somebody else's responsibility, but all of us responsibility as a team. I have one goal by the end of this thing, just have a clear understanding of this CQI problem. I know we've understood it from the beginning, but then again, there is no harm in getting that impact done once more. Then now understand the role of a leader in when doing CQI things, and especially in these times of COVID. We all know that service delivery in healthcare is led by these 5 sectors. The Constitution of Kenya 2010, we have Vision 2030, then we have Global Commitments, the SDGs. Those are the things that guide us. Then we have Kenya Hospital Strategic Plan, the Healthcare Strategic Plan, and finally KHP 2015-2030. Those are the things that guide service delivery in healthcare. And basically, all of them talk about quality in each and every item. Let me give a reminder of what quality is, and as defined by the Ministry of Health, it is in totality everything you do which satisfies a stated health need. It doesn't matter your department, you are a cashier, you are a nurse, you are a doctor, everything, even including procurement, whatever you do, and if it's satisfying the intended need, you are doing something quality. Even if you give the best treatment of malaria, and the case right now is pneumonia, whatever you are doing is not quality. And the Kenya Quality Model of Health recognizes 3 things that we should stop working from. We know best what you need, but we get concerned with the customer. Whatever the customer need, we tailor our services in relation to their orientation. And then we also have to realize that we are working from doing things post-evaluation, as in you assess and see where you did a mistake, then you start correcting, to a way of doing prevention and continuously improvement of the processes. Then finally, we are looking at looking things from the external focus, looking on controlling through inspection. We've stopped doing inspection audits to check issues, but to design a system that will enable us to offer a proper service. There are 4 things that confuse healthcare workers, and especially those who are not so well conversant with quality. They will tend to call you quality control, quality assurance, quality improvement, quality manager. They are differentiated in a very good way. When you're told that you're working as a quality control, you're just going to identify a problem, then fix it. You don't prevent, just say we have a wrong surgery done, then identify what happened, then fix that wrong surgery issue. Then we come to quality assurance, whereby you have done previous benchmarks, then now you're working onto the way of preventing problems. For example, if you have an issue that you are doing wrong medication or giving medication at the wrong time, you identify the way you are going to achieve it by ensuring that treatment is done at the right time. That is quality assurance. Then we do quality improvement is continuously raising the quality standard. You've done the benchmark, you assure that you're going to give proper care, then you continually raise that quality standard beyond the current standard that you are doing. Then when you talk about quality management, you are coordinating all the things within the institution or within the organization or within your jurisdiction to ensure that you are offering a proper service. In quality, you can't talk quality without going through the PDCA cycle, whereby in planning, most of the work, that is where it is done. You are forever identifying where the issue is, especially times of COVID. All of us, COVID was new and we were caught off guard. It's something that caught us in a mix. Identifying the real issue was quite in a short time, planning for that solution, getting stakeholders, planning on how to do it. Most of the work, if planning is not done well, you will not always get it right. So the moment you've planned and then you've identified the big pain of the institution, of the department, and you've engaged various stakeholders, then now you identify a solution and plan to implement it. That is totally in planning. Then after, in the process of implementing, you train people, you collect data and analyze everything to see if it is giving you the desired results. The continuous checking and going back to planning is what is done in CQI. And this is part of where is the role of you as a leader comes in. And remember, I said in the beginning, a leader is not that CEO up there. And I remember it was said like that yesterday by Kijabe presenter, that the CEO is not the sole leader, though the CEO leads the bigger institution, but you are a leader in a small place. Leadership in CQI, successful leadership depends on the structural support in learning systems, as well as supportive culture. Let me tell you, in healthcare, the institution where you're coming from, if the culture is not supported, if you don't support, if your leader is not supporting a proper quality culture, you are not gonna achieve much. And then resources must be used properly. Institutions in healthcare, we're using so much resources, but you're not getting the desired results. The reason being is we are not supporting a quality culture. We are setting aside that quality office somewhere, and then we are working, and then we are saying that quality, let her come, let her do something. But we are not putting it into us like it is our responsibility. And finally, I want to say that serious students of quality will seek out opportunities to improve. You are always on your here. What is Kenyatta doing so that we copy it to Kikuyu? What is being done in Chogoria? That is always serious students. Well, that's what they're always doing. I want to come to the part of the roles of leaders in CQI. I have summarized them to very minimal. Number one, a leader has to set a quality vision and a goal in the institution. Even, let me come down to the clinical officer in a primary healthcare facility. If you are there in that department and you are thinking that the ministry up there is bringing visions and goals to your department, there is a small portion that you can push before that bigger person comes and says, aha, Emily is doing something here. You have to set a quality vision. And remember, this vision setting is something we did yesterday by the HESMA chair secretary. You have to understand that setting a common vision will get you into a good culture as an institution. When you're setting this vision, you have to involve all your stakeholders, all. And then after that, communicate strategically for commitment. This is Kikuyu Hospital's mission and vision and core values, done strategically by the head board management of the hospital. Our vision is to be the preferred Christian center in provision of holistic health services in Africa. Then you will come down here and see the quality policy will have to mirror that bigger vision. This is the PCA Kikuyu Hospital's quality policy statement, which says that Kikuyu is committed to provide and deliver quality and affordable healthcare services to international standards. So when COVID strikes, you go back to your quality policy and try to see whether you are able to work towards that statement. After that, come to the lower department and set a quality objective. How are you gonna achieve that quality goal up there? I have picked the quality objective of the departmental unit or of the dental unit. Sorry, I didn't tell you, Kikuyu has 4 units, dental, general, and orthopedic. And this is the quality objective of the dental unit. The objective is to establish the customer satisfaction level with a view to improve it by 10% in the next 12 months. I know all of us know the thing called SMART, which we've learned over and over again in our academic journeys. The objective you're setting has to be achievable. It has to be SMART. Anytime you set this objective and it's not SMART, you have to go back and see if it's going to be achieved, and continuously. So when this objective is done in the dental unit, that is how the head department, the departmental head of this unit is responsible for the bigger thing. But if you're the nurse in charge of that unit, you have to ensure that you are doing this in your nursing section. The dentist has to ensure that he's doing this in his dental section, together with the community, the dental cohort. Yes, they have to ensure that they do their work in relation to this objective. For this, Kikuyu Hospital has committed, you can see that is the CEO's signature, which was done in 2019. And the policy statement is displayed in every single department. And whenever you forget, you are pushed back to remember that this thing is what is the reason why we are waking up to come here. The third role of a quality leader, you have to create an environment that allows constructive accountability and constructive conflict. Constructive accountability is where you have a shared aim. If you are the leader of, for example, outpatient, after setting the departmental objective, you now set appraisal targets and set up a quality team, a work improvement team in your section to ensure that that departmental objective is being achieved. Then we have you have to allow constructive conflict. There is a time that you will never agree on issues. There has to be a forum that the groups will sit down, discuss, and identify the differences of opinion and eventually develop a solution. A good leader in CQI, I don't know how to delete this word leader so that it doesn't appear that it's somebody up there. You have to remove barriers to success. Remember, you have an objective. Your objective is to ensure there is satisfaction. And this satisfaction, customers are complaining there is no sanitizer. You have to ensure that at any single time, these sanitizers are being provided so that we don't lag back. And continuously, the work improvement team and the quality improvement team of the whole institution should be going and checking if their department is working towards that common goal. Then you do coaching. There are times that you'll have people who don't know what to do. You've done new improvement, you've done new recruitment. People have left, people have come on board. People have forgotten. Remember, coaching is not telling. You train me to be the right person to do this work so that I do not major in my strength. The next thing is to do a celebration of success and failure. In most cases, and especially when you're mirroring quality thing, we will always say that department is not doing good and celebrate a department that is doing good. We have to celebrate failure. Sometimes you fail, even to an individual level. When you fail, sit down, pat yourself and say you did it, you rise to fight again, and then do it the next time it comes up again. Normalize failure and always go back to the PDCS cycle and challenge yourself. Where did you go wrong? Because there is a place you missed. That is why you failed. When this is celebrating a small win, dental unit emerged the best in one of the audits we did. Is it audit? Let me say one of the rounds that I done. When you celebrate a department, you see they are so happy taking selfies and their department is so nicely done. It was an assessment of how well they are in relation to the whole hospital. They match the best. The next time we do this audit, every department wants to be the best and get celebrated in the institution. Number 7, you need to earn trust. Trust you me, if I come to you and I want you to improve on something and I don't look like you can trust me, you will not do it. you have to ensure that you earn the trust. This trust, the CEO needs to earn the trust, the administration team, the head of department, the worker down there, even me as a junior nurse working in a male surgical department, my supervisor and my patient needs to earn my trust that I can give this treatment well. If the surgeon comes and takes the patient to theater and can't trust me that I'll nurse this patient, it is the same case with quality. If a gynecologist will say, I'm not comfortable with Emily nursing my patient, how can now you as a quality person, if people can't trust you, how can they do what you're telling them to do? Because in the name that it's going to improve something. Then work on self-awareness, know your emotional intelligence, assess yourself and let people know that whatever you are doing is good or bad, then working with and through others. You will never achieve alone. Nobody has ever gone to the journey alone. You need people, and the people will enable you to shine. And when you've risen up there, know that you are not alone. Pick another person, let that person go up. One of the things that Kikuyu has done in relation to COVID and quality, it has been able to do early screening of any suspected cases and implement IPC measures. There is hand washing, minimizing crowding, and use of mask and isolation measures are now done consciously. You know that time when it was hepatitis B and PTB, that's what we were isolating. Now it is now more like everybody's alert. Every single condition is a condition that brings into our mind what to do. So in conclusion, leadership for quality healthcare can be achieved by three things. You commit, commit, and commit. You need to invest. Investment in terms of time and in terms of knowledge and in terms of reading and in terms of support. You can't go wrong in investing in quality, and you can't go right if you don't invest in it. Then establish core values to quality. If your core value does not mirror quality, you can't achieve much. So attaining quality does not occur overnight. It's a process. It takes time. It takes effort. It takes leadership. Again, I keep on saying that as much as I'm saying leadership is everybody down there, if the vision bearer up there, again, doesn't support quality things, doesn't encourage employees, that doesn't reward good character, again, it will be very hard. And especially in times like now, when we need to be resilient in ensuring that quality things are being supported in an institution. That is the end of my small presentation. I want to appreciate all of you, and in case there is any question, you can type it. And thank you so very much.
Very big thank you to our first presenter and main presenter, Emily. Indeed, we have learned a lot, and thank you for emphasizing that indeed leadership is for all of us, and quality improvement is this certain everything else to happen, and for it not just to happen but to get better. We will go to the next presenter. We'll welcome Dr. Adam. She's from Kijana Mission Hospital, by background, and who supports health systems. Thank you very much, Dr. Mary Adam. We are glad to hear something that is a little different, quality improvement, but resiliency from the community side. She was part of the panelists, so it will be a short presentation. Mary, you're very much welcome.
Thank you very much, Lydia. I'm in the process of linking things up so that I can share my screen. I think that means the other screen sharing will stop, and I will move into this so that I can share and go to slide sorter view. Lydia, thank you so much for having me join to talk a little about what's happening in the community. I represent Kajabi's maternal newborn community health response to COVID-19. And for us, this has been an opportunity to try and bring hope within a climate of fear. Kenya's community strategy addresses health promotion and prevention at the household level. But when COVID came and hit, and in March, President Kenyatta stopped public gatherings, recommending people stay home and limit travel to flatten the curve, our fieldwork was grounded. Our fieldwork is very relationally driven, working with groups to do training. And so we had to be resilient and did a major pivot to properly respond to the challenges COVID-19 brought. In doing so, we built on community health strengths that are at the heart of what we do, especially things like sanitation and hygiene. So the first thing we did was collaborate with our local county ministries of health to reach hard-to-reach villages. In Kiambu, they had been given quite a few posters, but they had no real way to get them up. So we started to mobilize with that. We went to hard-to-reach villages, giving public disseminated messages with a loudspeaker, talking to boda riders and food vendors, shop attendants. We covered more than 1,300 kilometers sharing COVID-19 health prevention and information. But after that phase, we really needed to address something we saw bubbling up, which was the incredible crisis in mental health. Our team developed a training to address mental health support and psychological first aid. We built that on the WHO psychological first aid material and delivered it to the community health volunteers, community groups, and pastors, following precautions consistent with reducing the potential for spread. The demand was huge, because not only did communities need the extension of our routine work in wash, sanitation, and hygiene, where we could help them remember how to build and improvise hand washing stations, they needed more. They needed to address these emerging, really significant mental health problems. The demand for mental health training was huge. We had to scale it down in terms of numbers of a group. You can see here, we're delivering a mental health training outdoors, well-spaced, people in masks, following all the possible precautions that we could. The demand was so great, we even developed this training in a What's Up format, which you can see here, where we focused on the 3 areas: look, listen, and link. Look and see the situation from which the person is affected. Listen and have a good conversation, and then move forward to try and link them to families, community resources, and the support systems that do exist. So far, we have had more than 670 people go through this training addressing mental health needs at the community. We did this for community event-based surveillance officers who were part of the COVID response. We did this for pastors groups. We've done this for women's SACOs, because people have been saying, how do we cope? And I want to say it's been wonderful to watch people move from fear to hope. The fear has been palpable at the community level. As you see in the first quote, in members' own words, our community members fear to attend the health facility. They fear being tested or kept in quarantine. From family members, we are meeting men who have withdrawn from their families due to stress. I met a man talking to himself, and when I asked a question, he said he has no food for the day. And the stress from loss of jobs. But this mental health support was designed to help people move from fear to hope. Training that has touched our lives. We'd been doing things in a wrong way, breeding dependency, where you are helping us grow in problem solving. And the second quote in the middle, we think that the overall problem solvers, the linking part in psychological first aid, offers avenues for us to feel we can support the client. Before, we only thought of giving someone food or money. We never thought of linking these people to others. So Lydia, I want to thank you for this opportunity to share about some of the things we've been doing in the community to reframe our program in order to build on community strengths in engaging things for the COVID-19 pandemic. Thank you very much.
Thank you, Mary. It is always a pleasure to listen to another dimension after being in the part where we treat disease acutely. Going to prevention and community is usually very refreshing. And I think you've done a great job. The networks at the community really support the outcomes at the population level, and they prevent hospitals from being full. So keep doing what you're doing. I guess the Ministry of Health should be proud of you, of your team from Kijabe for the work doing at community, because it is not vertical for a program like TB and malaria, but it really is including the Nyumba Kumi and the various groups that are found in those communities. Please stay with us because there'll be a time for some questions. And then also at that time, I will ask you to put a little about your efforts at Acquire or what Acquire is. Next, we will go to our next presenter. We'll request Lynette from LVCT. They've done great work at the community to hear the in building resilience in the community during COVID and any other things they have on community. It will be great to hear. Welcome, Lynette.
Good afternoon, everyone. Good morning, good afternoon, and good evening to all of us from wherever we are coming from. So my name is Lynette Okoth, and I hope you can hear me.
Yes, we can, Lynette.
Yeah, so my name is Lynette Okoth. I work for LVCT Health, which is a Kenyan non-governmental organization that began in 2002. And we are an organization that is driven by our vision and belief, and our goal is ending new HIV infections in Kenya. Of course, not forgetting about GBV, which you do well, and community health programs. So we work through research, policy, and practice model, which is our driver. And diving into our agenda today, LVCT Health has implemented a community health program and research as early as 2009. And we are a member of Community Health TWG that contributed to community strategy, the revised version that is 2020-2024, and a member of COVID-19 Community Engagement Task Force. I want to just highlight the scale project that actually allowed us to implement QI at community level. And the scale is an acronym that actually means sustaining quality approaches for locally embedded community health services. That was in 2016, 2019. I'm trying to, okay. And our goal was to reduce maternal and child deaths in Kenya communities using a quality improvement approach. And this was a build-up from our previous work in other projects that was demonstrating how to use QI approaches within community health programs to actually achieve specific health outcomes in MNCH, and we learned that motivating community health workers at community level actually has impact in service delivery at community level. Some of the objectives that we are addressed was one, strengthen national coordination for improved quality of community health programs, increase capacity of national, county, and sub-county decision makers to prioritize and build community health programs using an equity approach for improved service availability, improve community health program performance in maternal, newborn, and child health, and strengthen community engagement in community health services. From these objectives, what you realize is that quality improvement cuts across community all the way to the national level, and any level that is bypassed then brings up challenges. And we also realize that community health it's where we begin our quality improvement. If our community members cannot make decisions early to access services, then we realize that even when we have very clear, very robust quality improvement activities at the facility levels, chances are we can always fail and not achieve our objectives. So during this project, some of the key things that we looked at, since it was a maternal and child health program, is we looked at 3 key maternal indicators, which was a referral for ANC, referral for skill delivery, and home delivery referral for postnatal care. Because you realize that when you address first antenatal care visit, if our mothers come early enough for treatment, then you realize that chances are we'll have a perfect skill delivery, and chances are they'll come back for postnatal care services. We also looked at 4 newborn and child health indicators, and we're interested in referrals for immunization. Are our children fully immunized? Are our mothers actually bringing children even beyond the measles at 9 months to still growth monitoring? Do our community members still bring children for assessment, for nutrition assessments? This is MWAC red, MWAC yellow, or other malnutrition. So one of the things that we also realize is that if some of these activities are not started early in pregnancies, it becomes very difficult to achieve. I also want to highlight that in this project, one of the things that we learned in terms of QI is that QI, we actually faced our project, our QI training, and we had it into 3 phases. The reason for doing this, we realized that when doing QI at community level, we really wanted to tone down QI to a level where a community member can actually embrace, a CHV will embrace, and a CHV can actually speak with and everyone at any level, and think through QI and actually talk at the same level in terms of how do we improve quality at our level. So we made it first so that we avoid overloading the community members with a lot of theories, but rather think through short trainings with periods of implementation so that we keep on reminding them about quality improvement. And this is actually, we actually have a training manual on QI that actually elaborates this very clearly and can be used by any level of healthcare workers to actually train community or any fast or close to community service providers. So what we actually emphasized on in phase 1 is, can we have quality, can these community members actually establish quality improvement teams? And why were we saying this? We realized that QI is about teamwork. QI is about responsibility. So how well do we identify or come up with teams that can actually work together and ensure that we actually embrace quality improvement activities? We just wanted to allow the teams at that level at first to even just have introduction, just basic concepts about QI, and just understand and see the importance of data quality, because we know that CHVs or community health workers collect data. In most cases, they collect this data as a routine activity, but never have an opportunity to actually interrogate and realize the importance of them collecting that data, because they inform decision making at higher level levels in the health system. So then we allow them to go back for close to 1 month to just understand themselves, form these teams, then come back in phase 2, and now we are now thinking through what were the key problems that the community members identified in the community. How do they present this data? Are they in a position to do problem identification and do root cause analysis at their level? And lastly, do some change plans or QI improvement plans to allow them now monitor what they do, what activities they've had, thought through to ensure that they've improved what challenges they have. Then go back again. Remember, I said we made it a phased model where they do QI, we train them, they go and implement, come back. So then they come back in phase 3, where our interest now is we have several quality improvement teams at community level that now come and share what they've learned, what they've done, and they learn from each other, because you realize that when you come from different counties, you might be having the same challenges in the counties, but your strategies to address those challenges in the varied countries differ. So how did one county implement QI vis-a-vis the other? And if all of them achieved their change plans or whatever they wanted to do, then what are some of these best lessons that made them achieve that? So I just want to, I don't want to dwell into achievements, but I just want to go through some of the lessons learned that we had in the project. And one of the things that I want to highlight, and it's very important for us as QI champions, and even as we move quality improvement in our health, in our facilities, is that institutional readiness is very key in implementation of QI. And we are saying that QI is not different from anything. We're just saying that when you're doing service delivery, then you have to do it with quality. So when you're ready, when you already have all the service providers are trained, we have necessary equipment, we have necessary commodities, then how then do we improve quality in terms of service provision? And this starts from I'm not sure whether Kenyatta has community units attached to it, but since the national level. But when you have an institution that is attached to a community health unit, so how well are the CHVs in that link facility capacity built to be able to identify some of these conditions early? How vast are they with the health facilities that they're attached to? Because it's very easy when CHVs actually act as doctors in the community. So when they interact with community members and tell them, go to Kenyatta, go to door 5, you'll get a sister in charge, she's called Lynette, and she'll accord you services. And they find that. You realize that that relationship works best for the community members and also works best for achieving our health indicators. Then you're saying that community units identified must have link facility with existing referral services. If you're referring community members from the community, it's very important that you have a very close relationship between community unit and the link facility. Remember, community units do a lot of demand creation, while the facility provides service delivery. So how do the two speak in one accord to ensure that quality is provided in the right way? Then ensure membership of which our work improvement teams or quality improvement team is well thought through. Remember, whoever constitutes a quality improvement team actually determines its success. So how well do we form these teams? So what does each and every person in this team bring to the table that ensures that we improve quality in our facilities? Then we also have sub-county level and county level support. Do our sub-counties, do our county health management team actually embrace community health services? Do they embrace quality at all levels? Because you realize that quality is well structured from national, county, sub-county, and probably facility level. But we realize that there was a gap at community level. So how do we make sure that there's continuum of care? How do we ensure that there's QI all the way from the community to the national level? And of course, buy-in and sustainability by community county health management team. We realize that when you're working with community health workers, these are service providers at the community level who are on a stipend, and more time, and they actually, I know we advise, according to the guideline, a community strategy is supposed to work around 8 days in a month, but you realize if you're working with community members, it's very difficult to actually say that you'll only work 8 days and the other 22 days you go and do your work. So you realize that almost each and every day they engage in the community. So how well do our counties actually embrace and think through having a bill, thinking through having a budget for community health services, and even paying them a stipend to enable them continue working in the community. In instances where now we have rain, like now it's a rainy season, how well are our counties are providing commodities for community health workers to enable them do household visits, to enable them identify or educate community members and do referrals in good time. So other things that we learned is that when you're doing quality improvement at community level, first training or workshop is an effective way to train, reinforce key QI concepts. We'll all agree, by my background, I'm a clinical officer. We'll all agree that the first time we did some QI trainings, either KQMH or any other models, we kept on reading, and for us it looked like a jargon. I don't know whether it was just me. But you realize that for you to actually embrace QI, then if it's done in bits, and especially for community health workers, when it's done in a first model, then they embrace this and actually use the information for a daily service delivery as opposed to one of training. It is very important for us to embrace coaching, mentorship, and ownership from the health, from the management. You realize that, and this is in the context of other projects, most QI projects are pushed by partners. So partners will continue doing coaching, they'll do mentorship, but how well does our Ministry of Health, county, sub-county, actually embrace these services, embrace coaching, to ensure that we embed a QI culture in the community, facilities, and even up to national level? Supervision and technical support is very key for for service provision, and is very key for quality improvement. Of course, tailor-made approach and flexibility. And you're saying that it's very essential in QI. You realize that if you're working with community level members, you might even be forced to train in local language. What you're interested in QI is how well can that CHV embrace quality improvement in whatever language they understand, but they can understand that when you're talking about quality improvement, you're moving from what I know from where I am now to where I want to be next. Then think about creating demand for use of data at community level. We realize that the ministry has done so much in terms of availing, in terms of having policy documents about community health, and even data collection tools. But you realize that CHV, since they do not understand the indicators so well, more times these CHVs just report for the sake of reporting because they must give in the report. But when you employ quality improvement at community level, what are we saying? We're saying that this CHV can actually, when they report to under maternal death, they actually understand why or what that too means in terms of numbers. So when they embrace this, then it's very easy for community level service providers, even for the link facility, to actually sit down and say, we had 2 maternal deaths in the community. What does this mean? Where was the gap? Was the gap with the community level in terms of referral? Was the gap at facility level? And if this where we had the gap, what are the local solutions that will help us address QI at this level and ensure that we have 0 maternal deaths in the community? So I also want to dive back to lessons learned amidst COVID. And one of the things that we've learned in implementation of QI and even working with community health workers and from both community level up to the national level is that flexibility is very important. You realize that when it was first announced about COVID was announced in March, everybody was confused. And at some point, even CHVs were forgotten. that close to community service providers who are CHVs were very essential. But we realized that as we continued having numbers, then we all realized that for us to achieve this, CHVs are close to the community. They understand this community. They can help us with community-based surveillance. They can help us with doing referrals. They can help us with identifying those people who've run away from quarantine, from isolation centers. Then it becomes very easy to implement QI and even address emergency or pandemic situations like COVID. We also realized that we could find expertise in places where we never thought that we would get expertise from before. And everybody was very busy looking at how else do we achieve this? How else do we ensure that all of us end up with a very low, flattening the curve? We also learned that even CHVs could even do masks, could even, if CHVs were empowered as IGAs, could do masks, could sell them, could come up with local solutions of how do we ensure that we have a stand so that we have all our community members wash their hands, all our community members mask and all that. Number 3, use challenging situations as opportunities to advocate. I think COVID-19 has actually taught the entire cascade of community health fraternity that this situation has been used to advocate for more support for community health work. And even as I'm speaking now, we realize that as a result of COVID-19, currently the Ministry Community Health Development Unit is actually coming up with a digitized platform for ensuring that community health workers actually give information to the community using an e-platform. They learn through an e-platform and even report through an e-platform. And we are looking forward to better prospects in terms of ensuring that community health work is actually improved as a result of learnings that have been done during COVID. We also realize that being healthcare workers, when resources are scarce and traumatic, all of us, and I know most of us in this forum are healthcare workers, and I know all of us at some point felt like the government did not provide. But I want to applaud all of us because in quality improvement, you use what you have to actually achieve success, regardless of how far you stretch yourself. And you want to say that healthcare workers actually stretched, they've actually innovated. I know we have a lot of innovations, and looking forward, Lydia, to a time where we'll have actually a conference or a best sharing forum where healthcare workers will actually showcase during COVID, amidst COVID, what did we do separately? How well did we use our little resources to ensure that we flatten the curve in service provision? Again, in QI and during COVID, do look back. I know most of the times we forget, but I think it's important that we look back in terms of what we've achieved, what we've done since March 2020, when the first COVID case was announced, and where we are now. For me, I think we've made good strides, and we've done so well in terms of trying to flatten the curve. It's important to look back as a QI approach to just pick the best lessons and sustain them. And whatever we do not do right, then we can actually look forward and say, this was not done right. We look at the processes and not the individual, and just forge our way forward as QI champions, as QI providers in the health facilities. And I think without so much, I think I want to rest my case at that point and say that thank you very much for the opportunity, and looking forward to the questions and the discussions moving forward. Thank you.
Thank you very much, Lynette. Once again, I think community are very refreshing and they are real. When you look at the pyramid for healthcare, the hospital setting serves very few, but we all are in the community, and preventive and promotive services should be consumed by a large number than those who come here when they're sick. So really, the lessons that you're learning and at the scale you're doing it, it is amazing. Please stay with us so that you can respond to some questions. You can also look at the chat box so that when that time comes, you could respond to some issues or issues that are raised. Allow me to go to the next panelist, Dr. Frank Wafula. Dr. Frank is a lecturer at Strathmore University, and he specializes in health policy. I think when you look at the landscape of quality healthcare in Kenya, he will be remembered. I'm not saying because he's old, but I think he's done a lot in terms of the joint health inspection checklist. He led that process. Then there are other studies on regulation framework for healthcare professionals, and then also supporting care through IFACE and World Bank, and doing policies on private public partnerships to support healthcare. So really, Frank, we're glad that you are with us this afternoon to give us some highlights on matters resilience and COVID. And also we are glad that you're here also to represent Society for Quality Healthcare. So Frank is the deputy, or rather the vice president for Society for Quality Healthcare, while I'm the president. I'm glad to have such a well-abled and experienced deputy president. Frank, you're welcome. Frank? Seems Frank has dropped off. Maybe his connection, he was offsite. So I think as we wait for Frank to rejoin, let us go to Emmanuel Milimo. Emmanuel works with Farm Access, I think Kisumu region, and we had an opportunity to get the safe care standards and the highlights in our Tuesday presentation. And so really we are glad at the work that Safe Care and the team are doing to support standardization of healthcare and to give us a form of, certification program for which many facilities in Kenya have taken up. So Emmanuel, you're welcome. You can briefly introduce yourself and share your highlights. Thank you.
Good evening, good afternoon, good morning to all of us from wherever we are. So I'm called Emmanuel Milimo. I work at Farm Access as a project manager. And apart from quality, I also do project management. And I'll quickly share what I do with all of us. But maybe just to start with is my resilience story. And I think as an organization, that is what we believe in, and that is what we would always want to do at all times. Let me just try to share my screen quickly. So I begin. Yes. I don't know if you all of you can see my screen.
Yes, we can.
Okay. So I know you've been told about self-care and many other things that we do. But we also, during this COVID season, we managed to take up a challenge, and that is to support the healthcare system in Kisumu to respond to COVID. And when I talk about resilience, I think JFK reminds me of many things. And in a speech he made at Rice University in 1963 says that they were not going to the moon because it was easy, but they're going to the moon because it was hard. And that is a call for all quality people, anyone working in the field of quality. Don't be fooled that it doesn't cost. It's easy. It's not easy. It is a game of resilience. It's something you have to do again and again and again and again. And I think resilience, even just the word itself, talks about getting back, standing up, going back to try again, seeing how best you can do it. And I think it also talks about the fact that things will never be the same. You'll do something today that is good, and the following day, the Lancet publishes something and it says, whatever you're doing is redundant. And I think that is the core of quality. So we don't stay on the front lines of quality because it is something that is easy, but we have to always remember that we do it because it is hard. And that is, I think, my resilience story. So In terms of farm access, we also believe in doing things digitally. And we believe that digital is a way to go because it creates efficiencies. All our standards are now being moved to digital to just make sure that we are as efficient as possible, we are as fast as possible to do each and everything and at the most cost-effective way of doing things. So what did we take up in terms of a challenge this time when COVID came, in terms of leadership? We looked at the whole COVID response and we realized that there are so many inefficiencies from procurement to delivery of results to tracking the samples from one point to another. And we designed interventions for that. And we came up with a project that we call COVID DX. Basically, if you make it long, it's called COVID Connected Diagnostics. And basically, connected diagnostics is a concept that helps you to connect each and everything in your diagnosis pathway. Just make sure that you don't diagnose somebody in the lab and by the time they reach the doctor, the results are not there or something is not right with whatever you're doing. So to make sure that we are all interconnected, but also at a very fast speed with the best quality that we can achieve. So what we did is, when you looked at the COVID response,
Manuel, are your slides moving? Or
no, they're not moving.
okay. Oh, they're great. I just needed to confirm that is the case. Thank you.
Yeah, they're not moving. I want to tell you the story and then I'll move to show you the slides quickly. So
no problem.
Yeah, so the COVID response was mainly based in the public sector and the private sector was left out. And I think when a healthcare system runs like that, it basically exposes 50% of the people who access healthcare in the private sector to an infringement of quality, because if I go to a private facility and I'm told if I need a COVID test, I have to cross the street or walk down or get to a bus to go get tested, it becomes very hard. So we try to solve that problem by training the healthcare providers in the private sector to have the skills they need to test, to have the PPE they needed, and not just that, but to give them digital tools that will help them transmit results and get results back. And we've done this in Kisumu County. I'll also share with you at the tail end just a quick highlight of how our dashboard looks like. And also we believe in the fact that if you don't have data, then you are not playing in the field of quality. You have to produce data. I liked what PricewaterhouseCoopers some time back in the strategic plan, they say that in God we trust, but to you, you have to give us data. So when you claim you're doing quality, just to go back, we have to always have this data. So that is what we try to do. I'll just run through my slides to show you what we did. And we hope and we believe it really improved the quality of service. It really made people to access whatever they needed to access in a faster and better way. I'm avoiding talk about self-care because I think, Dr. you told me you talked about self-care. So I just want to tell you about something interesting that we are doing at Farm Access. So what we did is we developed a project and we called it COVID DX, or COVID Connected Diagnostics, and basically worked with the county government of Kisumu, KEMRI, and Farm Access. And the idea was to strengthen and build capacity in the private sector to just make sure that they can also test and offer better quality of services and diagnose more precisely in case it's COVID for their patients. And to just increase that collaboration and also make sure that we have data, as I've said, and we digitalize all these processes, which means you don't need to worry about where your sample is, but you can see that my sample is being processed at KEMRI. My results have been dispatched. They're already in the dashboard, and that's what I'll show you later today. So in terms of the components, basically we were selecting the provider, we were training them, we're providing them with PPEs, also providing courier services, because transporting such infectious samples really requires a lot of skill. So KEMRI came in to help us do that. Then also to link the testing or the sample taking sites with KEMRI, and then digitalize the whole process. And at the end of the day, measure and objectively evaluate ourselves. What are we doing right and what are we doing wrong? That is one of the places, one of our facilities that we take samples. That is, I think, the laboratory clinician, the nurse are getting ready to test people. And then this was our client number one, sometime in June. That was our first client. And so far we've done we have 7 facilities. We've trained over 30 healthcare providers. And at that moment we had done 506 six patients with a positivity rate of 11%. This is just for your information, but I'll share with you. And this is what we meant. So what we went to improve quality or to do something exciting is to digitalize the whole process. And digitalizing has a way of leapfrogging all our quality aspects. So we digitalized the papers and made them we made them into digital forms where people can transmit and key in the information and get the information to Cambridge and have the results come back. Then that is basically the flow of how results go in real time from the clinic to Cambridge to the tool, to the database, processed, and then back to the clinic. Just a quick format of how it looks, the representation of how data flows. And then maybe just for the challenges quickly is one of the biggest challenges we had was procurement. And I think for us, the resilience story here was that we stayed on, we did not give up. We went and ensured that our private providers had the best quality of PPEs, no matter the cost. They had the best quality of transportation medium, swabs, and each and everything they needed. They had the best tools to use. Then approvals, we stayed on. And if we didn't stay on, it means that we would have left the 5 facilities. And I think we stayed on to make sure we get the approvals and everything going. And then the flow of results. One of the things that we realized that the results going to the lab and back to the facility, it was a very big challenge. And we went into solve and improve that quality or improve the turnaround times of the patient, which is a very important indicator in terms of quality. Improve it by digitalizing. And then the other thing was the codes. Every county, every sub-county wanted to have specific codes. So we had to stay on and ensure that they understand that whatever happens, the code will always go to them, because if you collect samples in a certain sub-county and the other sub-county feels you're not using their codes, it becomes a very hard story. So that became a very good point for us to take leadership and go out to the county and not give up on the project, but develop codes. You know, the codes for naming, like you can say Kisumu, you can say KIS-MOH-630, something like that. So every person wanted that code to reflect their unit so that they're seen to be working. And at some point, they even wanted to close and be like, don't work with us. But we had to stay on because we believed in the issue of quality. Technical issues of Wi-Fi, challenges of reaching households, because some of them were stigmatized, they were afraid. So somebody could have signs and symptoms, but we cannot go there because, hey, if you show up 3 months ago, if you showed up in a bodysuit, in that coverall, that would be very traumatizing, even to the family. People will avoid them. So it was very tough for us to do that. Then, of course, developing digital tools and sharing with government decision makers, making them to look at this tool every day to make better decisions, to use data for the first time in their practice to make decisions, to ask them why they're deciding to do what they're doing in terms of procurement, in terms of investment, in terms of decision making. What data are you using? That has always been our resilience story of us staying on to tell them, yes, you have to use data. Sometimes it backfires on us, but we are staying on to ensure that each and every decision relating to quality, relating to clinical decision, relating to any clinical, non-clinical decision made within the healthcare system is based on digital platforms. I think that is what I'd like to share. Let me just share with you our dashboard quickly so that you can appreciate what we are doing. Let me just stop sharing and share again. So this is where we stand in terms of the dashboard. So whatever we do, everything I've told you, the small things, keying one aspect of data to the next, this is what we are trying to do in our small way of improving the quality of COVID, or staying on, even when people don't understand what we're doing, because up to now, most government systems are using paper-based reporting, but we're telling them that, guys, why can't you use a system that works, that you can make decisions and understand? So the dashboard is like this, and you can always see we've done since June, we've done 1,800 tests. 167 of them have been positive, and yes, this represents 16% of the work done in Kisumu. We have 7 facilities. We have 7 couriers who deliver our results and ensure that everything is done. So they carry the samples to the lab and ensure that they're well represented or delivered in the correct format. Then this is a representation of our facilities in Kisumu County. That is how they look, the 7 facilities that we are working with, and their names are there. You can see where they are. And this is just to enhance that you can even make a decision. And the bigger the dot shows, the bigger the test that we have done. And that can be a very good tool for you to make. Can you imagine if you had all the country mapped out like this? We can see where each facility is, where the positives are, and how we can even intervene to make better decisions. So this is what I told you. As you can see here, where I'm pointing is these are the number of tests that have turned negative. 167 are positive. And then you can go in and see that 65 tests are being processed as we speak now. And these are the efficiencies we're talking about in terms of quality. You can actually also see the tests that are, which facility has done which tests and what is going on in each and everything. And then another cool thing I want to show you is if you want to know more about these 167 people who have turned positive, you can always click and see which facility has the most number of those positives. And this can be related to many, 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 many things. So this is what we are sharing with them. And you can actually see and even support Avenue more if you're working on that platform, or support them to achieve their work, because they're putting in a lot to get that. And then then the other thing that we do is it shows you basically, we also can map out the symptomatic and symptomatic, you can track them over time and see what is going on. You can also see the signs and symptoms of people who are presenting, what is going on in each and everything. And then this is also what I wanted to share with you before I leave. You can see here, it tells you where the positives are and how you can intervene and make everything better. So that is in a nutshell what we are doing. And that is our resilience story of staying on, even when things were tough, even when not everybody believed that you could use data or digitalized quality. That is what we've done. I think I'll end there. I was given 7 minutes. I hope I've not spent too much of your time. And I'll stay on in case there's a question for me at this point. Yeah, over to you, Dr. Ari.
Thank you very much, Emmanuel. We are glad to just get the other aspects of ICT and its enablement for us to monitor and have more efficiency in our systems. And indeed, COVID has been a game changer in how things should be done. It has pushed us to the limit. And so we've had to adapt to this. Actually, from the Ministry of Health perspective, the main equipment or testing facilities we have, they have capacity for a lot of data transmission, monitoring, but it's unfortunate that I think the reagents are usually not always there. So when you do the manual system, I think an approach that you've shared would have been of great help even to KNH. And once again, you bring the public-private partnerships and the potential that has to just bring efficiencies. Let's go to the questions and any responses from the team. I think I will ask Dr. Karume to lead a few of the questions as she puts them together. I think I'll ask Mary Adam to talk about the acquire, and then also in case there are any questions for her, she will respond. There's something from Dr. Odwori from Quality Health Kenya Awards, that those who've presented, you are asked to consider nominating yourself, your projects, your team members to the Kenya Healthcare Awards that should be happening, I think, next year in April, but the nomination maybe is soon to begin. We will ask him to just clarify maybe on the chat box so that we also pick that up. It's been a very exciting 4 days, and so it is good that it's being linked to other things that are happening. Dr. Mary Adams, kindly respond to those a question on community, whether there are policies concerning the community strategy and whether those are available, and then also a little about acquire. And then Karume, we can see in case there are any other questions you walk through that.
Great, thank you, Lydia. The first question I want to answer is, yes, there are available documents to discuss Kenya's community strategy. Lynette may be able to put the link to those into the chat box, or find a way to get you that specifically. And then I'd like to tell you a little bit about Acquire. Acquire is a collaborative effort. It stands for the African Collaboration for Quality Improvement in Frontline Healthcare Workers. And I'm delighted to be working with Dr. Lydia Okutoy, with Kenyatta and Kajabi as lead institutions. We currently are connected to healthcare organizations in 5 countries in sub-Saharan Africa. And our goal is to find ways to grow quality improvement here in the continent, right where we are, for frontline healthcare workers, people who are interfacing with things every day. So we're excited about that new initiative, and you're going to hear more from and about Acquire as time goes forward.
Thank you, Mary. Maybe just to vocalize some questions that have already been answered. We appreciate a lot of the feedback that we're getting about how these sessions have been useful. Thank you. It's enabled us to continue doing this and given another opportunity. So the slides are usually, the recordings are usually available on our website. I think it takes about a week or so to have them be put up to the website. You can kindly follow up, and you'll be able to pick this. Then on matters, I think there was another question about the community strategy have already been responded to. It goes in hand with the manual. I will ask Lynette to give more meat to what Dr. Adam has said. So Lynette, do you have any comment on that? And once again, Lynette, I think LVCT and Squel, you're doing a great job.
Thank you very much. Allow me to say that we are reviewing, and I think it's almost near done, the current community strategy 2020-2024. And if you do not mind, I'll get the copy and probably share with Dr. Kutoy. You can probably share with the rest of the team, just to allow us to best see what is the current information on community strategy and implementation of community health services in Kenya. Then secondly, I'll also share with you the QI for training manual for quality improvement training manual for level 1 or community health services, how well we've toned down the KQMH model to train community health workers and embrace all QI aspects in a simple, jargon-free way. Thank you, and over.
Thank you, Lynette. There was a question about the other webinars that you're interested in. So we usually keep a record of those who have registered. Of course, all of us here are in the KNH system, and so the mails, I think, should be out by Monday or by this evening on the breastfeeding. I think there's a webinar on storage of breast milk and how just to increase the options for working mothers and their knowledge and attitude. So that should be out by end of today. So we are all part of the system. So you will get an email in that regard. Going back to any other issues, I think we have mentioned all of them. Emily, you are our main presenter. So just a question to you, as you mentioned about continuous quality improvement and the learning health systems that should be a premise for us to do what we do better. You quite mentioned about the departmental objectives and all that going into appraisals, and all of us working towards this common vision that is shared. Yeah, so I'm wondering your experience in Kikuyu on the roles that are played by quality improvement and teams, and those that are played by the other institutional organs, assuming that like Matters vision and strategy, they are premised, but maybe they are played by other departments in the institution. I don't know whether when we talk about clinical governance, whether there is a separate local specific role for QI teams, embed themselves, say from the bedside to the boardroom, how embed the main vision of the institution. I don't know whether I'm clear, but I'm asking about QI and strategy. Emily, if you could give a comment, I'll be glad as we come towards the close of this session.
All right, thank you, Lydia. The quality improvement team is divided into 4 sections. We have clustered it into 4: nursing, clinical, services, and administration. And when we say that, when we talk about administration, we mean the administrative staff, procurement, administrative assistants, finance, ICT. It has representatives who sit in the bigger QIT and who form as the lead team in the work improvement team of the administrative departments. Then we have the nursing QIT, which has nurses. The nursing is the major workforce in all healthcare departments, and they're in numbers. So they have quite a representation. And to us, depending on the unit you're coming from, we ensure that every unit is represented. Then we have clinical representatives. These are doctors, clinical officers, pharmacy, lab, medical records, the doctors plus the support departments that support clinical work, all clinicians, that is. And we ensure that every unit is represented. And below them, now when we have a lead person representing pharmacy, down there is a pharmacy work improvement team. And the head usual of that department they report to the director of clinical, who represents their issues in the hospital management team. Then finally, we have the services. Services work team represents the services manager, all catering team, laundry, all those support departments. And together as a pool, because you have a quality improvement team representing all those things, together as a pool, they now form the quality improvement team, but below them work improvement team in their departments. Then all their views now pool to the hospital management team. So every section is represented. That is the structure of Kikuyu, but it can be replicated to other institutions in a way that can work for them. Yes.
Thank you very much, Emily. Yeah, indeed, every organization adapts to what already exists so that it is easily taken up. And thank you for enabling us to understand and also learning. As we come to a close, there's a comment from Kerry about Matters Compassion, and this being an important topic of leadership and also handling resilience during QI. Actually, leadership was one of the greatest contributor to having successful rapid learning. Because remember, when we had COVID, the first patient coming to Kenya, we hardly had much information, and even the globe was still learning. But there's a paper done by IHI, Institute of Health Improvement, on resilience during COVID, and also talking about matters of joy at work, because there was a lot of tension and anxiety. So as a leader, as a quick succession of learning there were approaches that they proposed, including compassion, leadership, which had matters of delegation and giving space even for people because we had less information and the resources also still being gathered. So I think matters of being able to delegate and delegate gracefully, in that knowing that things are not perfect, and also allowing those who are at the forefront to make decisions, trying as much as possible to bring power back to the front line. They can say where the PPEs and call the stores as much as you think that they should come through and through and through. So really compassion is important not only for the patient, as we talk of what matters to you for the patient, but then also even to the frontline workers and the entire cascade of leadership. It's like that as we have stress and unstable situations, we are able to be able to have resilience. Even people have emotional energy to continue offering the leadership that they support, and having Wanjiku receive the best care, just because somebody at the background is thinking through and thinking very fast and not being afraid that my supervisor will come and be very annoyed because I made this decision. But given you're making the best decision within the limited time, so compassion during leadership and ensuring there is joy at work was very important and will continue to be important because we are still in the pandemic. Once again, thank you for all the presenters. Thank you, Emily, for leading us through the CQI experience, coming to Dr. Mary, who presented about the community engagements in Kijabe and the mental health training that enabled us to learn that you look, listen, and link, that you don't always need to have all the solutions, but you can connect to care. And going to Squell by Lynette, and finally getting the innovation from Emmanuel. We are truly grateful for these wonderful, wonderful presentations. And also we are happy that the members have enjoyed and have shared that feedback. We'll continue doing what we can, given another opportunity. KNH will endeavor to support quality improvements in the hospital and at national level. So on behalf of healthcare quality, and Agneta Chelimo being the head of the unit, we are really grateful that you took time to join and be with us, and we learned together. So the only space that remains is a space for improvement, because you are employed to do your main work, whether you're a sweeper or a doctor or a biomedical engineer or a nurse, but the other work is to improve what you do. So continuous quality improvement is a premise that any forward-looking leadership cannot ignore. And so let us equip ourselves, let us share lessons, and let us learn together and celebrate as we assure that Wanjiku will receive care that is safe, that is effective, and that is responsive, given with dignity and respect to everybody that comes to us or to the community that we interact with. Thank you for your contribution to this discussion. Allow us to bring this to a close. Asanteni.